Cool. Okay. Well, I can't see everybody all at once with the speaker mode like this, but I don't think I know very many of you guys anymore. I only recognize a couple of names, but my name is Grace. I am from the UAMS class of 2019, and right now I'm a second year family medicine resident at KU in Kansas City. And I have been in touch with Reed and a couple other people about coming back to talk to you guys kind of about whatever. And so I thought that I would talk about the things I wish I had heard when I was in medical school about family medicine. I wouldn't say that it is a super influential department at UAMS, and so there's a lot of misinformation about it. And so obviously you guys are kind of self-selected because you're interested, but I wanted to talk about a couple of different things today, if I can click in the right place. Oh, yep. Okay. So a little bit about me. I know a lot of the examples people give about matching is very abstract, and so I thought I would just use myself as an example of how you can get to where you're trying to go without being particularly impressive, because my resume was not particularly impressive. Step 1, 204, that's like nothing. That you can, everybody can do that. I was in the 3rd quartile of my class out of 4. I got that improvement on step 2 CK that they tell you to look for. I had a lot of volunteering, but not a ton of research because I don't like it. I had a couple posters and oral presentations, but most of those were just things I did at UAMS, like through interest groups, like the 5-minute thesis competition and like the public health mini conference that they had in my year. And so I put these up here not to be like, here is someone to like model yourself after, but to make you feel like you can do this too. Like if I can do it, like you can also do it. I had a couple like small leadership awards, but nothing super fancy. And for my letters of rec, I picked family med, OB, med peds, and infectious disease. So I am again. And we'll talk about residency stuff, but just to give examples, I applied to 38 when I applied, I guess that was 2 years ago now. I was invited to a little over half of those. I attended 11 interviews and ranked 10 programs, and then matched at my number 1, which is KU in Kansas City, where I am now. In this talk, I wanted to kind of split it into 3 parts. Things that, looking back, the way I had organized my time, or the way I wish I had organized my time in medical school, deciding if family medicine is definitely the right fit for you, and then once you decide, how to get to where you're trying to go, which for you guys is residency. So in med school, I know we have a mix of all the classes. I'm kind of assuming mostly M1s and M2s because that's how it always goes at these meetings. In M1, I literally, all I would want you guys to ever be doing is to just be alive and like get used to med school and make friends and have like a social support. Icing on the cake would be to start figuring out the scope of different medical specialties, because it's really different from what you see on TV. And in particular, family medicine is different than what most people think it is. And particularly it is different, or can be very different than the way that it looks at UAMS in your clerkships and the staff that you interact with. M2, your only job is to pass step 1. Everything else is fine. If you happen to have time, that's a good time to start volunteering or shadowing if you're trying to still figure out what the scope of different specialties are. And the only way to know if you like it is to spend time doing it. But you're not going to have time in your 3rd and 4th year to actually do everything. So sometimes, especially if you have something that's a very niche interest, you need to do a little footwork on your own so that you can spend time seeing it and being sure that it's really what you want to do. But that can look a lot of different ways. It doesn't have to be shadowing, because you may not have the opportunity to shadow the type of physician you're wanting to see in medical school because they may not be in Little Rock, which is fine. A lot of my personal research into family medicine was honestly through social media, particularly Twitter, which is actually how I know Corbin, is from Twitter. But in these first 2 years, you're just trying to get through those didactic years and start to get an inkling of what different specialties look like and what components go in each specialty, because that's how you're going to start to narrow down, okay, what field am I going to apply to? In your 3rd year, you are going to, like, the time is going to pass by a lot faster than you think it's going to, and it can be challenging, especially when you're on a rotation that you're like, I know I am not a surgeon, and here I am on my 8-week surgery rotation. I am not excited. But each rotation has something to teach you. And in the case of family medicine, literally every rotation does have something to teach you. It sometimes is the lesson that you never want to do that again in your whole life if you can help it. And sometimes the lesson is that you really like it and want to incorporate it into your practice. There is not a lot that other specialties have that no family medicine doctor has, which I'll get to a little bit later in my talk. But your job in your clerkship years is to just pass the things you have to pass and really start to think about the elements of medicine that you like, which specialties have those elements, which ones can you not live without, and then how you want your activities for your ERAS to look, like how you're spending your extracurricular time and how to structure your application so that you can get to the place you want to be. 4th year though is really very easy. Like all you have to do is finalize what specialty you want to go into, and the rest, like I would just recommend chilling. I spent a lot of time in my 4th year rediscovering my hobbies and kind of getting my life together before starting residency, and 4th year goes by even faster than 3rd year. So once you go through the first 3 hard years, it's kind of your reward for doing all those challenging things. But the big highlights I wanted to say for picking your specialty is that every pot has a lid, which that's like a very colloquial thing, but my family says it like you will find the place that you are meant to fit in, and you will find the specialty that you love, and you will find the program that you love, and you will find the job that you love. It is out there for you, and the hardest thing about it is deciding what you want those things to look like, because you have this whole wealth of opportunities that it can be hard to pick, and it can be intimidating to try to start narrowing it down. But the point of these clerkship years is to listen to your experiences and to figure out which elements of medicine you cannot live without. I'll talk about mine a little bit later, but that's really what you need to do is like, do I like this? Do I not like it? If I like it, do I have to have it as part of my life? Like there may be some parts of medicine that you enjoyed, but it's not necessarily a deal breaker for you. And so that values-based decision-making is how I personally recommend going about making this decision, because if you're making it on like what other people say you should do, or you're like, well, I got a 279 on step 1, so I should be an orthopedic surgeon, right? Like not necessarily, because that's not the stuff that's going to make you happy when you've been doing this for 20 years. When you're deciding like, okay, these are the pieces of medicine I want now, which specialty does that fit in? That means you have to know the scope of all of the specialties, and people are kind of notorious about not knowing what all family medicine can do. Obviously, you guys are going to have a better appreciation than most, but knowing the scope is really how you know, like, is this actually something I can't get in the specialty I'm interested in, or is it just maybe less common? This is a slow process, and it is okay if you're a 3rd year who doesn't know what they want to do. You still have time to figure it out. This is an important decision, and you don't need to rush it. I wanted to talk about the scope of family medicine care because I did not know it for a long time. The stereotype that you hear a lot on like residency websites or people talking about family medicine is like cradle to grave, which is taking care of every need for every person for their whole lifespan from birth to death. So your standard training in family medicine, just about in any residency program, is going to incorporate these things. But whether they're part of your future practice is up to you. So if anything you're interested is on this list, then family medicine might be a good fit for you. The things that I have arrows next to, which are obstetric care and delivering babies, ICU care, and then ER or urgent care. The reason I have arrows next to them is because they are routinely part of family medicine training, but they are not always part of family medicine practice. These are the things that are more commonly found in family medicine jobs in rural settings, because we are an excellent fit to be a hospitalist in the middle of nowhere, where they can only afford to hire one hospitalist, but you can take care of kids, you can deliver babies, you can take care of old people, you can do procedures. And so even if that is the type of lifestyle you want, it is still a thing. Just keep that in mind, because that is a diminishing part of family practice in urban areas, because there are other specialists available. But all of these things are things I do every day, and if any of them are things that you're interested in, I promise you there is a family medicine doctor out there who does only that, or any combination of these things that you can think of. There's somebody out there doing it, which is something a lot of people don't realize about family medicine, and it's something I appreciate a lot because I really love variety. I find a lot of trainees say that they are torn most often between family med and OB, or family med and either medicine or med peds. And so I was kind of thinking about what types of things are maybe drawing applicants to these fields versus family medicine, because there's very little that those other specialties have that we don't have in family medicine. And so let me move this out of the way so that I can see what I typed. So between family med and OB, like, we are all trained to take care of women. We are all trained to deliver babies. We do prenatal care, postpartum care. We do LGBT care, gender affirming care. Sexual and reproductive health is not just an OB thing. That is most of my work. That's most of what I do in my clinic. Particularly within things like family planning and abortion. The majority of that is actually done by family medicine physicians in the US. With IM or med peds, they get to take care of every organ system like family medicine does. They get to do more behavioral health, which is something OB does not have, taking care of kids, taking care of men. Sports medicine is very big in family medicine and internal medicine, but all three of these, you have the ability to do fellowships and subspecialize. You have the ability to do procedures. It's not like family medicine doesn't do procedures. It's not like we're not in the operating room. And then there's also a lot of customizability and variability in any combination of inpatient work, outpatient work, both out there for you. I picked family medicine. I was actually originally die-hard, like, OB only, because I want to take care of women, because I care about women's health. So that means I have to be an OB. I think I hear that attitude a lot at UAMS in particular. And a lot of trainees I've talked to who are still students there feel like, well, that's how you take care of women, is to be an OB. But I spent over 200 hours volunteering at 12th Street when I was in med school, and I found in my time there that women's health is more than like the reproductive organs, and it's a lot more than just delivering babies and just doing pap smears, and I do those things and I care about them a lot, but women are much more than those parts. And they have unique health needs besides whatever is associated with those particular organs. Women have different cardiac presentations, women have different mental health needs, women have different understandings of how their body works and hormones and changes in managing their diabetes through menopause. And so realizing that was pretty big for me, because I had really kind of had that buried in my brain that if you care about women and you want to take care of women, you have to do OB and you have to be a surgeon. I also, in my time at 12th Street, really found that I care a lot about yeah, I did spell that right. Okay, underserved care. I picked KU for that same reason. I wanted to work with a really diverse patient population. I care a lot about working with refugees, and particularly in resource limited settings like 12th Street or like global health work or pretty much any safety net clinic like 12th Street. Family medicine doctors are really uniquely positioned to provide the most care for people with the fewest amount of staff. We have just such a broad skill set that we are really leading a lot of these global health efforts because we can do it all. I also, obviously, I like the variety. I don't want all of my day to be the same. I don't want every week to be the same. I don't want all of my clinic visits to be one of 5 different things. But that's a reason I hear a lot, so I thought I would mention it, and it is true. And the nice thing about it is, even if you get started and you realize, you know, actually maybe I wanted to do something else within family medicine, you're still trained to do it. And so if you see yourself maybe having multiple interests throughout your practice, that's an option for you. But I also wanted to talk about advocacy. Obviously, literally anybody at all can be an advocate for patients and just for people. And any physician can be an advocate for patients on the individual, like advocating for this particular patient, or on a bigger scale. But I found that the culture of advocacy within family medicine is very strong and kind of uniquely values advocacy, not just political advocacy, but at the level of getting things done for our patients because we can, because we're taking care of all of these needs for our patients. We're more likely to be taking care of underserved people. We're more likely to be in rural areas, operating with fewer resources. And I was really drawn to that. And that was also a big part of why I picked KU, is because the culture of advocacy is strong here as well. Okay. Once you pick family medicine, which some of you or most of you, I'm not sure, may have already done, your next task is, hopefully you already understand why, but to start thinking about what you want your family practice job, or even just a semblance of it, to look. You see a little asterisk next to it because it's okay if you don't know. This is really just ideally you would have some idea, because it will help you pick your residency to know which areas within family medicine you like. You saw that giant slide. I'm not going to scroll back to it, but there are a lot of things within family medicine, and it is pretty common that people have interests, like sub-interests within it. Even if you don't do a specialty like fellowship, even if you don't do extra training, it's okay to have niche interests within family medicine. For me, they were women's health, sexual and reproductive health, and advocacy. So having a shorter list than just family medicine will make a big difference for you, because there are more than 700 family medicine residencies in the United States. All of them are different. There is one that is like just perfect for you, and you will get there. And it feels like a huge task to like find this needle in the haystack of the program that's going to get you to where you want to go. But thinking about your future practice goals is how you start to narrow that down. There are a lot of really great databases for residencies. The AMA has one called Frida that I think you have to pay for. But the AAFP has one that I think is free for members, and I think student membership is free. Social media now, especially since we had to do interview season virtually this year, programs have really been updating their websites and their social media. But then there's also a lot of stuff like Reddit and Student Doctor Network that I personally didn't do, but I know that a lot of people really lean on those for kind of insider information about residencies and kind of how people's experience went when they interviewed and stuff like that. And so all of these things are fair game. You just need to start thinking about, like, if you know you like family medicine, what you're trying to be really strong in, if anything, and then things that you would like to see in your residency program, because like it is so weird, because for a long time, like especially getting into medical school, you're like, well, I'm just happy if I get in. Like I have these reach programs, but at the end of the day, I just want to match, and that's cool. But there's literally more than 700. You're going to have to narrow it down. You cannot afford to apply to all 700, and I could barely afford to apply to 38. But things that some people think about with residency programs is where it is, obviously geography with family or cost of living. But for me, I looked at geography for patient population. I'm bilingual in Spanish, and so I wanted a significant Latino or Spanish-speaking population. So I was looking at geography more for that reason. I was looking at program size, the number of residents, because if they have fewer residents, it does not always mean that there is less work for you to do. It just means there are fewer people doing it. Looking at whether family medicine is the only program in the hospital. I think this pretty much only happens with like family medicine and sometimes OB, that sometimes they're the only residents in the hospital. KU is obviously not like that. UAMS is not like that. People talk about it as like opposed, where there's other residencies, or unopposed, where it's just family medicine. I actually wanted opposed, even though it sounds like a bad word, because I do not see myself being the hospitalist who's by myself in the middle of the night in a very rural hospital who needs to know how to do everything and like run a code with one hand and catch a baby with the other hand. That's not what I'm trying to do. In the unopposed programs where it is only family medicine, they lean on you a lot harder to do things like run the code team and take all of the OB call. So thinking about your future practice helps you know if those programs are a good fit for you, because like for me, I didn't need that training, so I didn't really apply to programs that were going to give me training I wasn't going to use. Because there are other people out there who do want exactly that. And if that is you who wants that, that's awesome. Like, here's all these spots for you. So the more things that you can think about as being important to you are only going to be helpful to you. Obviously, no matter where you match, you're going to be a family medicine doctor at the end, and that is ultimately what's most important. But because there are so many, you can definitely find one that gets you pretty close to where you're trying to go, even if it's not necessarily your number one thing. This slide is kind of my pro tips for actually getting into the residency you want to do, instead of just like hoping you match, which is also fine. Like, matching is what we're here to do, but ideally, you'll get into that number one rank spot. But as somebody who's been doing now kind of on the other side, I've been doing tours and interviews for my residency program for the interns who will start next year. So these are kind of my tips from doing that. But if you say you're interested in something within family medicine or including family medicine, you should go do it in a way that you can put it on your application. It does not seem very authentic to say that you're passionate about, like in my example, women's health, but you have zero experience doing it. You don't seem to volunteer. You don't have any research projects. You don't have any patient experiences that really support you saying you like it. It makes it seem like you just haven't done your homework. Theoretically, if you're interested in it, these are the things you would be doing because you like it. But it is important, especially if you were like me and you changed your mind about what specialty you wanted to do. You need to have some of that in your CV to demonstrate that you're interested, but also to validate your own decision that you care about it. Because if you get there and you hate it, it's okay to change your mind. I had to sometimes, to pursue the things that I was most interested in, go off campus. But most of the stuff I did was through UAMS, like 12th Street. We I'm not sure if they're still doing it, but the Confidence Project is a local community outreach program that a friend of mine was doing. I did a couple research projects. I published some things through social media. I did my honors in research through UAMS, and the value of it is kind of like medical school, where you can say, I did this thing, it taught me this, and that's how I know that I want to do family medicine, and particularly whatever things you're interested in within family medicine. An easy way to start to not only like learn about practical things like programs you might be a good fit for, or places you might want to work later, but also just meeting the people who work in your field, and like meeting your like co-family medicine doctors is really valuable and cool. I think there's a little bit of a competitive atmosphere in medical school because you're all like competing to match, but you guys are actually all future coworkers. And you guys are all going to be working, some of you in the same communities, taking care of the same patients. And so I always recommend taking advantage of conferences and networking opportunities to know who is in the field with you, and make those connections, because you never know what doors it'll open for you, but also it's just fun. Values-based thinking is kind of pretty much everything I've been saying this whole time. If something is important to you, acting on that and pursuing that thing that's important to you, to me is always going to lead you in the right direction. And it's always going to bring you closer to the things that you value, because that's what you've decided to do. I didn't want to take all of my time, but here is some contact information for me, but I also wanted to give you guys some opportunity to ask questions about like residency or finishing medical school, or literally anything, or family med, or whatever you might like.
Grace, did you do the preceptorship between M1 and M2 year? And maybe you could speak on that for some of the M1s and M2.
Yeah, I did not, because at that point I thought I wanted to do OB. And in hindsight, I would have done it. I think particularly in the UAMS system, there's a lot of easy access to people who do lots of different types of family medicine, especially with the AHECs, like the more rural sites that are very like traditional family medicine, cradle to grave, like being the country doctor who does everything, or in Little Rock, the more urban, like focused primary care, urban underserved, like they do at 12th Street. But yeah, I heard positive things about it, but no, I didn't personally do it. I was a late convert to family medicine. I didn't change to family med until halfway through my 3rd year.
I have a quick question.
Yeah.
So I'm an M2, and we were just talked to about the lottery system for picking our classes and all that. And I know it's like different for family medicine. I'm personally interested in family medicine. Do you have any advice for that? Like how to go about ranking what you want to do for the family medicine stuff?
I am trying to remember my clerkship schedule because I liked it a lot. I think gosh, it's hard because you guys are also potentially dealing with COVID stuff, because a lot of students who were like saving their most favorite rotation for last, like then didn't get to do it before residency, which is terrifying. But I ultimately think that anything is going to be okay, but I personally put the thing that I thought I wanted to do pretty early. I did my OB rotation first in my 3rd year, and that was how I realized I didn't want to do it, was by doing it first. And so I would recommend trying to do the things you're interested in the first half if you can, just so that you have a little time to come up with another game plan if you get there and you realize you hate it. That also gives you more time to think about letters of recommendation, because if I had done OB last in my 3rd year, I would have only had a couple of months to come up with new letters of recommendation. And hopefully I would have realized by then that family medicine was a better fit for me. But just from a logistical perspective, I would probably try to do it in the first half if you can. But at the end of the day, like, it's all going to be okay no matter what your rotation schedule is.
Did they have it where for family medicine, like they had several sites that you had to go through and like rank them? That's kind of more of what I'm talking about. Like, I just don't even know how to go about that.
Oh, I see. I
Yeah.
think, I doubt it has changed significantly since I did it, but that pretty much depends on what type of experience you're looking for within family medicine. I think people had the most fun in Fort Smith because it was the most like full spectrum, because they got to be in multiple different parts of the hospital. They got to do ER, they got to do inpatient, they did outpatient, they did obstetrics. I went to Fayetteville because my family lives there and I wanted to stay with them. That one is all outpatient, which is good if you know you like that, but I would say that it didn't show me the full spectrum of family medicine very well. I think Russellville was also pretty popular for the people who actually wanted to do family medicine. But that one was very ER heavy, like urgent care, but that's very useful too. And then the Little Rock, I believe, was almost all inpatient, which is not super standard for family medicine. The way it is right now, the majority of family medicine docs practice outpatient and fewer than 10% practice obstetrics. And so if you're interested in any of those things, like by all means go for it, but each site has a slightly different emphasis. And so I would just go to whichever one has the emphasis you want. Because I know I was kind of being a bit of a baby about not wanting to go to a town like by myself, but like this is a very valuable training opportunity for you, especially if you already know you're interested in family med. So if you like ER, if you like OB, I would probably do Fort Smith or Russellville. But if you're like, no, I actually have a dog and don't want to go anywhere, that would be Little Rock. Or if you see yourself as an outpatient family medicine person, then Fayetteville would be a good fit for that too. Or Springdale, I guess.
Awesome. That was really helpful. Thank you.
Sure.
I'll add to Pine Bluff if you don't want to leave Little Rock and you're okay making that drive. It's pretty ER heavy too. You can get as much ER experience as you want there.
I forgot Pine Bluff. Cool. Well, please like write down these things if you have like a secret question. I can hang around for a few more minutes. But I don't want y'all to feel like you have to sit here and stare at me if you have other things to go do, which I know you do. But definitely feel free to keep in touch. I love mentoring trainees, and I have not kept as good contact with UAMS as I probably should have since I went there. But yeah, please feel free to reach out. I'm happy to talk your ears off about family medicine or residency or the social media, I don't know. 12th Street, whatever you guys are curious about, I am happy to be a resource for you. But yeah, it was good to talk to you guys.
Thank you, Grace. I appreciate it.
Of course, I'll hang around for a few more minutes. I don't know if you have announcements or anything.
Yeah. The only announcement I really have is our next meeting, we're going to try to meet with Dr. Clardy. He's very interested with staying in touch with UAMS students about rural medicine and family medicine. That'll be on, we're shooting for January 14th. That may be subject to change, but right now that's what we're going after. So that's the only announcement I have, but if anybody wants to hang around and ask any questions that they didn't want to ask in the group, hang around and can do that.
Hey, Grace, I have one question. I might have missed it at the beginning. I was a little late getting on, so I didn't want to. Did you talk about like the different procedural stuff that, you know, kind of family med can do, and all the different, I mean, I know there's like, you know, obstetrical work and things of that nature, but I didn't know like what all.
Not in detail, but I am happy to talk about it. Pretty much anything that is not a major surgery, like a transplant, there are family medicine doctors doing them. With like office-based procedures, it is very standard to do like small skin excision things like skin biopsies, lesion removals like skin tags or small lipomas or something. Especially I do a lot of reproductive procedures like Nexplanon, IUDs, pap smears, colposcopy. We'll do those in a regular clinic day. Vasectomy is super common. Joint injections, especially in sports medicine. Point of care ultrasound is becoming even more popular. What other things do we do? Fingernail, toenails, like I guess that kind of counts as a derm procedure, is completely standard in a clinic. Besides that, for procedures, a lot of family medicine doctors do like spine injections as well as joint injections for arthritis or injuries. People will do like inpatient procedures like paracentesis, thoracentesis. People will do colonoscopies. Obviously, obstetrics is a whole other set of procedures, but I guess I might as well talk about that. But within obstetrics, wherever you go, you're going to be trained in residency to manage labor. And so that in itself is a ton of procedures. Delivery itself is a procedure. Different residencies are going to have different amounts of involvement with C-sections, but everyone will have you do vaginal deliveries. Here we don't do C-sections, but part of that is just because now with obstetric care, with the way that medical liability stuff is, you pretty much have to do a fellowship if you want to do obstetrics, which is why fewer than 10% of family medicine doctors do obstetrics. Unless you're very rural, you will be required to have a family medicine obstetric fellowship to do a family medicine job that involves obstetrics. I personally don't care about it, so that's fine by me. I like prenatal care, but I don't plan to practice obstetrics after residency. But yeah, pretty much anything that is not a major surgery, we're out here doing it, and like dental, I guess.
Guess I'll kind of just ask a hypothetical question about kind of OB-GYN, the future of that with, you know, you hear a lot about family medicine is still doing a lot of, I mean, in training, obviously doing a lot of OB-GYN, but then you get out and less than 10%, and also like malpractice and everything, insurance and all that stuff. Do you see maybe in the future, like family medicine saying, maybe let's focus more on like, maybe in just example, inpatient, pediatric, stuff like that, and kind of move away from maybe not, you know, primary care like gynecology, but maybe more obstetric stuff?
Yeah, I kind of think they already have. Within, I think it was 2 years ago, maybe 3, the Board of Family Medicine, so you have like medical school, so that's ACGME, who's the boss of that, and then you have residency, and then that's GME, who is required to be in charge of that. And then you have the Board of Family Medicine, who says, yes, you have graduated a residency in family medicine, you've passed this test, you are a board certified family medicine doctor, and they're the ones who recertify you through your career. They recently removed 2 or 3 years ago the number of deliveries you had to have before you graduate residency, because so many programs are seeing a decline in obstetric numbers. I think that's kind of an American thing where you think like you're pregnant, you have to get an OB, you have a kid, they have to see a pediatrician, and because people don't realize that family medicine doctors can do those things. So those numbers have been going down nationally. And I think that was why they got rid of that number, because so many people weren't meeting it, but also it's only applicable to a pretty small percentage of practicing family medicine doctors. It used to be 40 vaginal deliveries. You'll find when you interview that they may talk about their delivery numbers, and some programs like mine feel that obstetric care is what differentiates family medicine from like med peds, for example. And so they feel kind of on a philosophical level that that needs to stay, but I do overall see that going down. And the truth of it is, really what differentiates us from med peds is not just the obstetrics, but it's also the gyne. Like, again, women are not just the reproductive organs, and we train in gynecology, and that's a whole ton of practice, not just knowledge, but also procedures and visits. Like, half of my visits in my clinic this morning were gyne. And so even if I'm never doing obstetric ever again, women's health is still a massive part of my practice that I'm well trained to do, that differentiates me from med peds, because they usually don't have formal gynecology training. Some of them will know how to do pap smears, but that's usually about all they do.
Hey, Grace, I have a question.
Yeah.
So I'm an M3, and I just finished the smaller 5 rotations this semester. And currently my top 2 specialties are psychiatry and family medicine. And I was wondering if you could talk a little bit about like the scope of mental health care, or mental health, treatment and care in family medicine, and kind of if you have any tips on people who've been torn between those, because, I would love to, do psych care if in family medicine, and just kind of anything on kind of deciding how much of, psychiatry you would want to do.
Sure. So I love psychiatry. I rotated at ASH, and that made me think about psych for a hot minute after I did OB, and I was like, okay, not this. Psychiatry is really a massive part of family medicine. There are a lot of programs that really strongly emphasize it, and I would say mine is one of those. And the way that they emphasize it is not just in having like integrated behavioral health in the clinic, like you have psychologists that you can go grab, which is nice, but it's also things like being trained in substance abuse treatment, and like getting trained to provide like Suboxone for opiate addiction, or like it's so much more than just treating depression and anxiety. But I will say, in my practice, probably between 1 in 4 and half of my patients have active mental health needs that I am in charge of. Within how much you want to do is kind of up to your comfort level, because nobody is going to stop you. There is not a maximum mental health limit for family medicine. It's not quite like OB where there's fewer people doing like C-sections and things, but for mental health and psychiatry, you can do as much as you're comfortable doing. A lot of my patients are only even receiving psychiatric care because of their presence in a family medicine setting, because they would never see a psychiatrist. They would never, like, there's a lot of stigma, and access to care is such a huge issue, and especially for rural and underserved communities, usually the only way they're going to get that care is through family medicine. And like I was saying earlier, that's a big part of why I like it, because I can bring gyne, I can bring psych, I can bring derm, because it's all me. And I know how to do all of these things. And so I can provide that care. And so if you were deciding between psychiatry and family med, what I would think about is like, what can you not live without? Because you will definitely have psychiatric stuff in your clinic all the time. And if you want to just do that, there are people that just do that. But if you want to also be doing their pap smear, if you want to also be like doing well child visits, or talking to people about their diabetes or their thyroid or weight loss, that was ultimately why I decided not to do psychiatry, is I wanted to do other parts of the body, not only the psychiatric stuff, but I still really cared about mental health treatment being in my practice.
Awesome, thank you so much.
Of course, yeah, good luck. It's really hard to pick. But yeah, if the question is like, can I do this in family medicine? The answer is almost always yes.
So I have just kind of a general question.
Yeah.
Yes, largely, a number of the family medicine docs that have been around have had largely geriatrics practices, and I haven't gone on my rotations yet. So I was wondering if you could speak maybe a little bit towards the pediatric side of what you've been able to experience so far.
Yeah, I don't know what it is at UAMS, but they have like it's like geriatrics more than family medicine. We nationally in family medicine residencies kind of having a similar problem with OB, where people think like I have to take my kid only to a pediatrician. They're the only person who can take care of my child because that's what the word means. So there's a little bit of that, but my personal clinic population, the average age is probably under 40. Most of my patients are young women. And nationally, I think the family medicine clinic populace is slightly younger than the average age of the population as a whole, and slightly more female. But yeah, definitely not only old people, but I would say if you do not, oh no, I only just opened the chat. Sorry, everyone. Geriatrics, yeah, so definitely not only geriatrics, but I would say if you do not want to ever see an old person ever again, that might not be the right fit, just because you are taking care of people for their whole life, and that includes when they are old. But it's definitely nothing like the clinic population I saw when I was doing my family medicine clerkships, or even just taking care of anybody in the hospital at UAMS. It was like, does anybody under the age of 50 live in Little Rock? But yes, there are there are still young people and peds, and a lot of in particular adolescents, because pediatricians don't want to see adolescents because they're like, I don't want to talk to them about sex, but adult doctors don't want to take care of them either because they're like, I don't want to do weight-based dosing for medicines, and I don't want to talk to them about sex either. Their mom is here. We are really well positioned for adolescent care, and particularly converting like newborns from the moms we deliver, and then taking care of that child as they grow is, in my practice, how I have gotten the most pediatrics numbers, because usually they also have like other kids and their partner, and mom needs a doctor too. So here we all are in the whole family. I wouldn't say that I was ever torn between pediatrics and family medicine, but it's definitely a big piece of it, but I wouldn't say a majority. But I wanted to also be with old people and with young adults.
Thank you so much.
Of course. Cool. Well, I would love to go grab some lunch before my next session, but please, you guys feel free to reach out to me. I think this was recorded. But yes, Corbin also has my contact information. Reed has my contact information. So you guys please reach out to me if you think of any questions later. I am more than happy to help, but it was really good to talk to you guys, and I wish you luck in your medical school journey. I promise it gets better. It gets a lot better. Residency is a lot of fun if you do it right. And medical school honestly was more fun than I thought it would be, but residency is a lot more fun. But yeah, good to see you guys.
All right. Thanks everybody for joining. Thank you, Grace. Everybody have a very Merry Christmas. We'll